Hello, and welcome back to Deconstructing Unconscious Bias in Behavioral Healthcare, brought to you by the Addiction, Mental Health, and Prevention Technology Transfer Centers. This is Session 2, Making the Case to Identify, Not Blame. First, I'd like to introduce Ms. Diana Padilla, who is a research project manager at the New York State Psychiatric Institute at Columbia University. Ms. Padilla has over 22 years of public health service, including curriculum development, the conduct of evaluation of substance use disorder treatment programs and problem-solving courts, engagement in chronic disease research and prevention, and the provision of classroom instruction to behavioral health professionals, prevention specialists, and drug court practitioners on behavioral health and recovery support practices. Next, I'd like to introduce Dr. Karen Glover. Born in the Bronx and raised in White Plains, New York, Dr. Glover has spent the greater part of her adult life following her interests in science, health, and improving life for the underserved. After graduating from Howard University with a BA in history, she followed her curiosity about medicine and ultimately attended SUNY Downstate College of Medicine and obtained a Master of Public Health from Columbia University's Mellman School of Public Health via the highly competitive Macy Scholars Program. Currently Assistant Professor of Psychiatry at the Albert Einstein College of Medicine, Dr. Glover teaches psychopharmacology and aspects of psychotherapy to internal medicine and family medicine residents.
Welcome back, everyone who was here last week. This is a 4-part series. Welcome for everyone who is here for the first time. I wanted to give a quick thank you to the leadership, the Addiction and Technology Transfer Center, the Mental Health Technology Transfer Center, and the Prevention Technology Transfer Centers. The three TTCs are together in on this. We cover the Region 2 area. That's New York and New Jersey, Puerto Rico, and the Virgin Islands. So for whether you were here last week or here for the first time, this is a series that we all came together to consider providing because of the current, it's not just the current environment, it's that has highlighted, it has really brought to light even more prominently than usual the inequities or disparity rates among racial and ethnic communities in terms of accessing behavioral health care services. But the current environment kind of seems to highlight it all that much more as well. And so what we wanted to do was to start to look at what we can do individually in our practices and what collectively we can do within our settings and in our disciplines to impact these numbers, these equitable numbers in terms of outcomes for people of color. And so this is why we have a 4-session series here. So what we did last week, we did cover the inequities and sources of inequities, where we looked at some numbers. We looked at what are disparity rates according to what we have. We also looked at the need, which is prevalent amongst Black and African American communities, the tribal nations, the Hispanic, Latinx, Asian communities. And so we looked at all that. We also looked at the fact that the services are not getting any better. And in many, many instances, there's such a deficiency that the numbers have actually increased in terms of poor quality of services or lack of access of services. So we looked at all that and we started to understand. Co-presenter Amy Banco really did a great job about going over of how unconscious bias impacts our work. And so we went through the psychological framework, the cognitive development processes, and how it kind of speaks to socialization and how it gets sustained. So today we're going to go into a little bit more continue the conversation, really bring it to our practices, really bring it to what we're doing with our patients and our clients and what hidden bias might look like in our disciplines. And we'll also talk about how to identify and mitigate the impact of bias. just to start us all off on the same page, the idea is, why do we want to assess and identify unconscious bias? This is something that supposedly, if it's unconscious, if it's implicit, if it's hidden, we're not necessarily aware of it. But if we don't look at this, if we don't talk about this, if we don't consider this potential part of that impacts these the racial and ethnic communities that we work with, then we can't do anything. And then these numbers will continue to increase for our communities. So we want to talk about different dynamics involved. So let me bring it back to where we are right now. Unconscious or hidden feelings or thoughts, that's what unconscious bias or hidden bias is. And typically they're negative or hostile or violent thoughts and feelings about a specific concept, something, a particular thing, or its communities or persons of color. And for our purposes, please borrow our ideas, because what we're going to do is really explore the dynamics involved. I want you to consider, as we move forward with the content, the title of this session. This session is intentionally called Making the Case to Identify, Not Blame. And we understand where a particular factor is impacting our work, and we can look at it and address it, then we can move to improve our efficacy around our patients. So although it might be difficult to identify, it's not impossible. We can address and resolve bias in our various capacities, and that's what we intend to speak about today. So here you have what might be a multicultural person, and she is receiving, someone is really telling her, but you speak so well. So what I'm going to show you is actual experiences. Here we see East Asian person. So this is actually from a study that was conducted by Dr. Daryl Wing Su, and his students were writing the comments that they are used to getting. So this young woman had this said to her. So what do you guys speak in Japan? Asian? Another thing that came up is this young Black African-American woman who responded, no, I will not teach you how to twerk. And she was a Harvard student. And so if you're Latina and someone tells you, you speak so well, you might hear other comments like, oh, wow, you're different from the others. They're really going to like you. Or, or if you're a Harvard student, and because you're Black and African American, you are told, you're commented on as whether it's jokingly or not, to show somebody how to twerk, or when you speak to someone who has a certain background and you're asking, what do they speak in Japan? So that is conveying particular messages. And here you'll see people from tribal nations. We are not a bygone people like the Vikings. We are here, we are now, we are not your mascots. So a lot of the names that have been protested against within the tribal nations, because a lot of NFL groups, certain NFL groups and certain sports entities do use these names. It really speaks to having a derogatory reference. So the takeaway messages from simple statements like this is not a helpful message. It is actually conveying certain type of ideas and feelings. So what we talk about here is really microaggressions. There are three different kinds of microaggressions. There are micro assaults. There are more explicit epithets, and they're a form of discrimination. They're like insulting, like visual displays that are linked to the association that someone has with a particular group, typically so a group of color and a marginalized group. Micro insults can be subtle and unconscious action, but they're like verbal comments that convey the rudeness, like cultural sensitivity at its best. Micro invalidation is like those comments like if like someone who might represent, and I'm coming from a perspective where I'm not assuming someone's cultural identity, But if someone is multicultural, if someone is Latino, Hispanic, or Asian, and someone says something like, so go back to where you came from. So micro-invalidation speaks to unconscious communications. And unconscious because maybe they'll say in a joking way, but it doesn't necessarily mean that it is a joke. It conveys and speaks to a person being an outsider, even if they are a citizen. So these are slight snubs, that can be intentional or unintentional, but it is a form of discrimination. So the impact of microaggressions. The internalized shame induced by repeatedly experiencing these types of experiences for an individual can make you hypersensitive, can make you very vulnerable in terms of your sensitivity, in terms of how someone might behave around you. So you're very sensitive to social judgment. It might even help leave you in a place where you become self-conscious and might internalize that there is something, wrong, that you're not like everyone else. And so there is William White. He's an expert historian on substance use disorder treatment, and recovery supports. And he suggests that it might be easier for some folks to face overt discrimination only because for some people it might be easier because it's easier to detect. It's more obvious, as opposed to putting someone in a stressful position where you're not sure, did they mean this as a joke? Are they trying to tell me something, how they really feel? So encountering microaggressions, because of one, perceptions are easier to validate. If may be easier to validate for some folks. This is not an absolute. So stereotyping, discovering the presence of a sex worker. Think about you're in treatment or you're in mental health, or you're in a prevention discipline. And in the file, there is the sex worker as part of the notes that were taken from the person who initially did intake and took the original demographic information and all the other correlating information that the client or the patient gave. And then it's noted in the medical record that a statement like this past sex worker. So this can result, this disclosure can result in biases as well. As I think about in the addiction field, if addiction is part of it and they're going to the mental health setting, if addiction is part of it or they were in prevention now, the fact that they had a certain past, a certain behavior can actually, impact the process of whether or not this person can obtain health and life insurance. And it doesn't matter a lot of times how long someone's been in recovery and good health. It's really interesting how human beings tend to remember or think more prominently of negative attributes as opposed to positive attributes. So there are times where stereotyping is also like when someone tries to refute one addiction or recovery status, because they may not understand. A lot of times this is based on ignorance. It conflicts with prevailing addict stereotypes when someone says, you weren't really addicted, come on, one drink won't hurt you. Or instead of being supportive, someone is kind of speaking to like, that's not really an issue. You really didn't have that problem, right? You don't have to keep going to those meetings. So the idea is that you're being exposed, the person is being exposed to non-supported, demeaning language, and it comes up with language issues as well. So these things, all these dynamics kind of speak to behavioral health bias. So the National Institute of Alcohol Abuse and Alcoholism, the NIAAA, have done a host of different studies and talks about implicit bias as how it threatens the alliance between practitioner and patient, between provider and client. So everyone has biases and we all transmit them unless we're aware and we try to use strategies or certain skill sets to be able to mitigate them. So, but these biases often escape the average person's level of awareness. And so it can create stereotypical language, stereotypical thinking, that which might affect or influence our behavior as providers and essentially lead to differential treatment. So these, the microaggressions toward the client, you want to consider the impact it can have on them as a stressor, and them on their mental health, there on their quality of life, particularly if they go through it often. And there are some environments where folks of color will go through it consistently, or it's stereotypical threat experienced by the client. So there are some factors that research has shown that are related and speak to racially biased outcomes. And here are a few. I want to talk about that. Racial anxiety. And so one of the things about racial anxiety, when we consider how unconscious bias influences our communication and our behavior, racial anxiety refers to the concerns or the feelings or thoughts that might come up just before or during an interaction when a person of color is speaking to a white person, or to a person who's white who's speaking to a person of color. And it's like this feeling of apprehension. Say for the person of color, it's like, they might be apprehensive of thinking that they may be discriminated against by speaking when they start to speak to this person, for whatever the reason, whether it's a host of different experiences or because the person, there was an idea behind this person, but the person of color is thinking, I said, they may be discriminated against. Typically, that's based on past experience. And so they get anxious. But then on the other side of that interaction, you also have the person, the white person who is really trying not to be perceived as a racist. And so that concern comes up. So that racial anxiety looks like that in a white person when they interact with a person of color, and they really don't want to come off discriminatory or racist, but what happens is oftentimes when these interactions together come together in the interaction, the concern and the thoughts actually influence our behavior in such a way where it seems like we're actually confirming the very thing that we're trying not to be. So a person who's trying not to be discriminatory, who's trying not to be a racist, not to act racist, it may have a hard time, may be nervous about looking someone in the eye, a person of color in the eye. The other person on the other side might be thinking, might change their tone of voice because they are already maybe thinking that they're going to be an address which is very discriminatory or stigmatic. So that anxiety kind of creates a negative interaction. So when you kind of think of those things tend to happen. And so the concern leads to behavior that may seem to confirm a bias. So things like that, or sometimes you can see it, for example, if sometimes someone is uncomfortable, sometimes you can see the uncomfortability. And while somebody is trying not to be racist, someone is trying not to be discriminated against, either side can be very nervous and want to hurry along so they don't have to stay engaged in the conversation. So these are the different things that might have a person of color with their increased awareness feel like they're going to be a victim of discrimination, maybe even violence. For a white person is the fear that they will be perceived as a racist. So the very things that one, either one might be feeling might be the very things that create the anxiety that actually confirms it in behavior or can be perceived from their behavior. So then there's another thing. There's also stereotypes, right? This is another dynamic that does affect the interactions and how we go forward in our practices. So it refers to a situational predicament. It's really it's stressful for folks who have to worry about their behavior might confirm a stereotype as someone that most other people might think of them and as they identify with a particular cultural group. And so that's pretty stressful to kind of have to, tiptoe, through what you say and what you do. And so that stereotype threat. And so it refers to a situational predicament in which individuals are at risk of confirming negative stereotypes about their group. So the term was first used by actually Steele and Arison back in '95. In several experiments they conducted, and they did it within the scholastic system, the educational system. So they went to a Black college, and they did several experiments, and they found that Black college, that the freshmen and the sophomore performed poorly on standardized tests when it was first prefaced with persons of color not doing as well on certain tests. White students, when their race was emphasized, also didn't do as well when that was emphasized. When race was not emphasized, Black students performed better and equivalently than white students. So what you say, your words have impact. And there was a slide here at the beginning of this presentation, and every presentation that we do, we're not just required to use it, we're actually grateful to have to use it because our language matters. The words should be, it's something that we have to consider using intentionally and not off the cuff, and not really think about how our words in context in a particular situation convey certain information, certain messages to the recipient, which is the persons of colors that we're talking about here. So self-confirming belief that one may be evaluated based on a negative stereotype. So stereotype threat is that very thing, that you're trying not to confirm that a particular stereotype that is perceived of your group. So let's talk about this too. The other dynamic is white privilege. That's the special and unearned right, advantage, or immunity granted to a group or to a person that identifies with a group or a membership of a dominant culture. And so it's more institutional. It's not necessarily more than personal, because as a group, it's a set of benefits granted to those who are white by race. Just automatically, it's not earned. It's not like they had to work at it. Automatically, you are part of a dominant culture. It automatically comes with its privileges. The same privileges that other people of color would have to work for, or persons, the white population do not necessarily have to work for. So that really speaks to the folks who have powerful positions in institutions, a lot of the decision makers, not in organizations and settings, in administrations. So privilege, particularly white, is hard to see for those who are born with it. So when you are born with it, it's very different because if you've never had to look at it. It's kind of like living in a world that you've never had to compare to another world because you only know what you know. And so, and I know that's very much layman's terms for really speaking to something that you've never had to actually acknowledge, but you live by and you live with. So it's hard to see for those folks who have access to power and resources, but very visible to other racial communities who don't have it. So this one is also pretty important, and I think a lot of what's that's gone on in the last decade or so, and especially the last year or so, really speaks to in-group preferences. The original literature and research was done in white in-group preferences, and the literature has evolved even more from there, where it's just in-group preferences. So it's usually delineated by culture. And the reason why it's in-group instead of just white in-group, because when you think about cultural environments, say, I'm going to talk about the criminal justice system. I've been working as support to problem-solving courts or drug courts for many, many, many years. And one of the things in that environment is that the culture itself, because of a certain authoritative, set of professionals, there can be a very different way of looking at patients and clients, and in that arena would be drug court participants. And so when you're part of a culture, whether you're talking about whether you're talking about law enforcement, whether you're talking about mental health practitioner, whether you're talking about addiction counselors, there's culture within those groups. So in-group preference really refers to that group that you identify with, where that membership is what actually influences your lens. So when people experience in-group bias, they tend to be more comfortable with, or have more trust in, or have more positive views, and feel more obligated and comfortable with the folks from their own group. And so think about how maybe there's a certain dialogue that's going on, that certain ways of referencing, clients in the addiction and the substance use treatment disorder treatment field. Think about when we see law enforcement or criminal justice system who are more likely to maybe look more punitively to offenders than look at it from the person having a particular problem to help. In-group bias really helps you to see from that perspective and not necessarily from the perspective you are looking at. So when we think about like folks who a lot of times in New York, when we had a lot of the racial profiling and when we're stopping the stop and frisk policies, which gratefully they're not supposedly the law says that we don't have them anymore. Doesn't mean it doesn't happen. I'm just saying that we don't have them anymore. But when we did have them, it didn't matter whether the police officer was Black, Asian, white. There was a culture of the police department that was more punitive in terms of in terms of the folks that they were picking out to stop and frisk. So it goes beyond sometimes your own racial and ethnic background. So it's an in-group bias. So that's what I mean by that. So it's like you don't see them yourself as a racist and not actively directly holding hostility or distrust towards persons of color, but your own cultural group and the dynamics there are influencing. Unconscious bias, it's all part of it, and it's influencing your behavior and how you go forward and work with people of color. So this is not an easy topic to discuss. The four dynamics, the four factors I was just talking about is different. Research has been showing how they do play a part in a lot of the consequent behaviors that are impacting communities of color. So while it's not an easy topic to discuss, it is necessary in order for us to identify and address the issues or the practices that we engage in, so we each can make a difference in terms of elevating our efficacy and being more culturally appropriate, more person-centered, giving more person-centered care and quality care for racial and ethnic minorities that we work with in our communities. So the potential of having implicit bias towards Blacks and other minorities will be difficult to discuss, but we know that we will be discussing it here as we go forward. Despite that there's a risk of being perceived as racist, what we'll pick up on is there's a lot more to it than just that. Overt racism is one thing. Unconscious hidden bias is another thing, and that's where we want to focus our efforts, because we're seeing too much of the consequences of it by not addressing it. So we want to understand what those advantages gained are based on discriminatory practices and how we're going to revise them to help communities of color. So here I'm going to go and I'm going to put unconscious bias in the clinical setting. So Dr. Glover.
The first thing I want to say is thank you for having me. So I want us to talk about some of the basic things that I think are super important. This slide was made by Ruth Shim and her group out on the West Coast, and they're looking at some of the really core concepts that seem to underlie some of the injustice we're seeing. It's been in our society for as long as we've had an American society, but I appreciate that this is a time for all of us to kind of reckon with them in a new way. So the bottom right bullet says structural racism. I think part of what underlies some of what's happening to folks in our society is not necessarily the result of interpersonal racism, right? Like not everybody is waking up with a cross burning on their lawn. Nevertheless, there are things that are built into our system that have an impact, whether we are racist or not, whether we are biased or not, whether we are consciously aware of our prejudices or not. So I just want everybody to sort of think through that as we go through these slides. One concept that seems to underlie so much of everything around us is race. And I just wanted to bring up that the concept of race, it is a construct, right? That there, especially with the Human Genome Project in the 90s, we recognized once we sequenced the DNA of humans, we recognize that there's actually 99% similarity between all human beings on the planet, and that the greatest differences you see between human beings are between human beings of the same ethnic group, ironically, not people who look different. So Johann Friedrich Blumenbach did not have access to that kind of technology. He had, in the late 1700s, early 1800s, access only to his biases and some of what he knew from looking at people. He lumped humanity into 5 groups. White people were considered to have come from the Caucasus Mountains. He said that he found them to be the most beautiful people. So he designated a certain hierarchy. He designated people that were East Asian as Mongolian, and American indigenous people as red, Malayan people as brown, sort of South Asian folks, and Ethiopian people black. So in any event, I just want us to keep in mind that science makes its advances, and then we recognize that, sometimes what we thought was reliable wasn't reliable at all. This is how it worked out, right? That over time, we thought science was giving us some really good information. Nevertheless, it reflected the difficulty, the racism of the time, the interethnic hatred of the time. And there's this a relationship between medicine and the culture. So at the time of Mr. Blumenbach, he looked at terms around people who were trying to escape slavery. And so you'll see at the bottom bullet, there's a term, drapetomania. So drapetomania was a term originated in the field of psychiatry. I'm a psychiatrist. I'm also Black. So this rings sort of, it resonates with me as the descendant of enslaved people. There was a psychiatric term for Black people who wanted to be free and who ran away from slavery. They were said to have drapetomania, sort of psychopathology related to merely wanting to be treated as a full human being. I bring up the term mongoloid because when I was a kid on forms, people with trisomy 21 or Down syndrome were thought to bear a resemblance to people from East Asia. And so the term mongoloid or mongoloidism was related to perceptions of Asian people as less intelligent and linking trisomy 21 with being some derivation of an ethnicity associated with being East Asian. So I just want you to understand that today's medical or mental disorder or some concept around it could be based on some really bad science. So and science that it reflects the racism of the time. So how does unconscious bias look in mental health? Well, studies were done in the early 2000s to look at rates of schizophrenia among Blacks and whites as considered and diagnosed by clinicians. And they found that Blacks were 2.7 times more likely than non-Hispanic whites to receive a diagnosis of schizophrenia. The thing is, the Black participants and the non-Hispanic white participants were verbalizing the same symptoms. It just happened that the Black people were assigned schizophrenia, were diagnosed with schizophrenia rather than there being a consideration for some of their mood symptoms. You guys may know, and pardon me if I'm repeating something you already know, but I just want to make sure we all follow that. When there's a presence of a mood symptoms, you cannot diagnose the person with schizophrenia. The diagnosis has to take the form of either bipolar disorder or schizoaffective disorder. But for some reason, Black participants who appeared to have schizophrenia, who appeared to have psychotic disorder or psychotic symptoms, their mood symptoms were not taken into account. So we know that not all psychosis is schizophrenia, right? But when the researchers went back and asked interviewers, hey, you seem to have missed the mood symptoms in these Black participants, the clinicians assumed that the Black participants were simply being dishonest about their symptoms. Like, Black person, who are you to have depression or some sort of depressive symptoms or manic symptoms? You are psychotic, and that's what I'm going to pay attention to. That's sort of the unconscious process that was happening with the people interviewing these patients and doing a clinical examination with them. So unfortunately, even though we want to not be biased in our diagnosis of the patients, we also want to make sure that sometimes these things are unconscious processes. So there are themes that seem to not disappear. They seem to come again and again and again. And among them are what we take away from the mental status exam and what we think the default should be on patients. So for example, there's lots of Black people who choose not to straighten their hair. So generally, Black people, the only people of African descent on this planet, have very, very curly hair. And when we wear our hair natural, sometimes people will say, I had a colleague say this to me recently when my hair was natural. She said, your hair is wild. And I thought, how interesting. This woman thinks that she's white, I am Black. Her default in her mind is that hair should be straight. Hair is straight hair. For me, in my mind, hair is curly. And so for her, curly hair means wild, right? And that brings up all sorts of stereotypes about Black people, particularly Black women. And so she and I had a conversation about what it means to what underlying assumptions there are. And so I think about some of our patients when they show up and maybe they're dealing with mental illness or substance issues and they show up for care. And when we write our mental status exam, when we describe the patient, what sorts of words are we using? How are we talking about their body and what they have a right to wear? If they're super curvy, if they are large people, if we know that there's data that shows that even young Black males are somehow assumed to be older than they actually are, right? And there's life and death consequences for those assumptions. And also when patients have tattoos, sometimes, especially in psychiatry, we often look at patients with their tattoos, and I've noticed differences in how Black patients and Latinx patients with tattoos are perceived versus white patients with tattoos. So that's something to keep in mind for how we're describing our patients. Other examples of bias that I think are really, really important, that when and I'll give my own personal example, I had patients, male patients, I work in the South Bronx, an area that is heavily policed. And it's an area where sometimes my patients just kept on arriving late. And I was like, what is going on with you? And I started to be sort of irritated and frustrated. And my patients were saying, well, I got stopped by the police and I had to go to court because I got stopped by the police. And I had to explain why I was in one location and they said I didn't have a right to be there. I got a ticket for loitering and things like that. And so I want to highlight for people that when groups of Black and brown men gather in public, they are, especially in New York City, where we have had a history of stopping and frisking only certain kinds of populations, i.e. Black and brown people. The outcome of that is that my male patients of color were being arrested for loitering, according to a history and tradition in this country of codes from after slavery, where people who were unemployed, who gathered in public to talk, to share support for each other, they were arrested. It was literally in violation of the law for Black people to gather in public in numbers more than 3. So the legacy of that is sort of still evident because my patients were being arrested for loitering repeatedly. And that was impacting their ability to engage with their mental health appointments and their medical appointments. It was causing delays in their being able to to get a job and to keep a job because they were constantly being inconvenienced and delayed as they tried to go about their activities of daily life. So I think it's important for all of us to understand, again, nobody's showing up at these people's houses and burning a cross on their lawn, yet there are disproportionate effects of policies like stopping and frisking people, or for enacting or following suspicions that 3 people gathered in a place while being Black are somehow being suspicious and are violating the law. Cross-cultural mental health principles are really important to consider in this case, because as we move forward and try to work toward being anti-racist and try to be anti-biased, it's important to consider that each of us has a role to play in advocating for our patients and even understanding where they're coming from. So there are impacts of cultural factors for all of us. So when it comes to assessing culture, I think it's important to understand that it's complex. Culture is sometimes the way the person looks, but often it's not. It's important to ask the patient, how do you identify culturally, and not make assumptions. Aspects of cultural identity include a lot of the things here, especially marital status, sexual orientation, religious and spiritual beliefs, level of acculturation, right? Many times I have a colleague who is a Black woman with long locks, like dreadlocks. Like, people have, especially she's from Ohio, and she said, sometimes people would say, your English is really good, but I still don't understand you. Your Jamaican accent is so strong. And she's like, I'm from Cleveland. What do you mean Jamaican accent? Just because I have hair like that reminds you of a Rastafarian, for some reason, you are thinking that I am not from here, right? So you'd be amazed at some of the barriers that some people have when they see somebody who is different from them. So questions to ask about people. Where were they born, and how did they get to wherever this interaction is happening? How did they get there? Sometimes when my patients even come in to see me in clinic, I mean, nobody's coming in lately because of the pandemic. This is all remote. But when they would come in, I would say, how was it for you to get here today? And you'd be surprised what came up. For some of my female patients, they would say, somebody was looking at me, a guy looked so menacing towards me, I had to get off the bus. And so I didn't want to stay on the ride. That's why I'm late. Or I didn't feel safe. Or for some of my patients who migrated here from Honduras or from Mexico or from other countries, they would say, I flew and it was fine. I had a cousin, it's all good. And then other people said, I had to walk through the desert and I caught tuberculosis on my way here. And that was just last year, and that stuff still haunts me. So it's amazing the sorts of stories that can come out. And some of these people get mistaken for African American, they get mistaken for being Asian, and it's only when you ask their story that you get the depth of who they are. So I think it's important to talk with them about what they want out of treatment and what results they expect out of treatment. It's important to keep listening. It's important to keep track of what the ways that the patient adheres to your formulation or the ways that they don't adhere to your formulation. Engage them about ways that their cultural background can support their recovery, how their culture interprets their diagnosis, the meaning of their culture, the meaning of their culture with respect to their recovery. To look at how we as clinicians and we as staff members, the sort of the power dynamic and what it means for our own biases when we're meeting a patient. So this quote from the US Surgeon General last in the early aughts, the culture of the clinician and the larger healthcare system essentially are equal the societal response to a patient with mental illness. We're in a great position to be helpful to our patients. But as the bottom bullet suggests, we've got to be aware of our own biases, attitudes, and stereotypes. So here's a slide to just underscore some of the aspects of understanding the dynamic between the patient and us, or the client and us as clinicians and staff members. The bottom one I think is super important. It's there because I give the example of when I first finished residency and I started seeing patients who were transgender. And I had so much curiosity about my patients' experiences, and I wanted to understand, and I didn't have a lot of resources. So I just figured, well, I'll just ask my patients the questions. The problem is that my patients were coming to me in very real distress, and I was asking cultural background questions about their trans identity, about the culture of transgender people in New York, and about their socializing, and it was probably at the expense of the right kind of intervention. So I recognized that I had to go for training, right? So that my patient wasn't being put to work to make me understand them when the information was out there somewhere. I just had to find it. And the good part about this talk today is that there's some really good links to lectures and podcasts so we can keep on learning. I think also understanding the spiritual life of our patients is really important. Taking a spiritual history as early as possible is really important. Using open-ended questions and making it part of an ongoing dialogue. You'd be amazed at the power of spirituality in our patients' lives. So asking them what gives their life meaning, what importance their beliefs have in their life, what spiritual needs need to be addressed in treatment, or where else they can be addressed. Because one thing I've noticed as a physician is that when I make a recommendation to a patient, they're going to maybe tell their family or their spiritual provider. And if their spiritual leader or advisor says, I don't think you should take the Prozac, I don't believe in that. Well, guess what? The patient's probably going to listen to that person and not me. I'm the new person on the scene, not me, not that person's spiritual leader. So here's a vignette that I think is important for us to consider also, which is the case of a woman who came to me because she had spiraling heroin use and some crack use as well. And she wasn't coming to medical appointments, and she kept on getting arrested because of the measures she was taking to obtain her substances. So I kept on trying to refer her. I kept on trying to refer her for help. And when it happened that she wasn't getting the help that I thought she very much deserved, she was like, look, you keep referring me to a program. Look, I don't do people. And just to make it clear to you how much I don't do people, when I get arrested, I try to act up as much as possible so that I can be put in solitary confinement because I don't do people. So essentially she was telling me, like, your culture of like seeing specialists and going away to a program where I don't know if people are going to know my culture. I don't know if they're going to know my traditions. Look, that's not for me. I don't do people, let alone people who are drastically different from me. So like, you can keep all that. I'll come back and see you. So I had to understand the level of trauma that she had, the level of cultural and racial trauma, but also her own personal history of trauma. And then I had to be very mindful of like trying to refer her anywhere, because I had to make sure I could appropriately match her with the kind of place I was sending her to. So in this vignette, I think the highlight is just that this is a 52-year-old African-American male who was HIV positive, had been diagnosed with lymphoma, and he was overwhelmed with anguish and anxiety, wasn't taking his HIV meds, wasn't functioning well at work. And he didn't really want to come see me. But one thing I noticed is that he was wearing multiple beaded necklaces, small beads with certain colors. And I recognized that that was a sign that he was a practitioner of Bukumi, or a Yoruba religion, or some people call it Santeria, which is a legacy of a spiritual path that some of our ancestors who are African American had. It's very more commonly seen in the Caribbean, but also in certain communities in the United States, especially South Carolina, and some of the Sea Islands, which is where this guy's family was originally from. And it's also seen a lot in New York. So it was when I asked him about his necklaces, they're called collares, that we could tap into this part of his identity, right? If I had just looked at a 52-year-old African-American man, I would have assumed, he's Christian, his family's from the South, and I would try to address him in a way that felt sort of familiar in that way. But I had to recognize, like, this is somebody who's on a different spiritual path, and it's important to acknowledge the role that it was playing in his life. So I think it's important for all of us, whether we're clinicians seeing patients, or in a leadership position within our recovery or substance use professions, or in mental health, how are we taking care of ourselves? How are our diverse staff members able to feel supported in their work? Because part of the work of being anti-racist and anti-bias is making sure that our staff adequately reflects the ethnic and diverse makeup of our society. So are we able to recruit and retain diverse staff? And when they're going through it, right, in the midst of a pandemic, in the midst of racial trauma throughout our country, when they need help, how hard is it, or how easy is it for our diverse employees to quickly connect with a therapist who will be familiar with their culture, a therapist or some sort of coach who's going to be anti-racist and anti-biased? How long is it going to take for our staff to find that kind of help? And then if we've got an EAP, are the people we're using as consultants for our EAP, are they anti-racist? And is our EAP scalable to the increasing numbers of people who are trying to get help? Knowing that now all you have to do is turn on your computer to see a therapist, right? So we know that barriers are coming down. We're in a very special time, you guys, for people, our staff and our patients, to connect with help. So I hope that we're maximizing these opportunities. I urge all of us on this call to be very mindful of how the upheaval in our society and these massive changes that are taking place. Let's be mindful of the toll that it's taking on us. When we wake up in the morning, are we excited to get out of bed and go to work, to go to clinic, to turn on our computer to start the work? Or do we need to take a break? And how can we maximize our ability to be patient-centered when we're in the room with the patient, or even when we're remote with the patient, and knowing where to put our energy during an intake process, and in the process of listening to our patients talk about some of these very, very traumatic things that maybe sometimes we're not so familiar with. So, and are we engaged with apps that add to our well-being or detract from our well-being, or is it a mix of the two? So here are some apps that I think are worth considering. And I refer my patients to these apps as well. One of them is Liberate. It's a meditation app that's narrated by Black people. It's led by clinician meditation leaders of color. So it's really interesting that meditation often leaves people feeling really vulnerable in that state. And sometimes they want to hear almost like permission or representation to be in that meditation space in a cultural way. Doctor on Demand is a way to connect with a clinician, a doctor, a psychologist, social workers. 40% of the staff at Doctor on Demand is people of color, particularly women. Ayana is another way to connect with a therapist who has done the work to be anti-racist and anti-biased. And then there's Pride counseling for our LGBT community members. I think it's really important to connect with somebody who's not gonna leave you feeling like a disempowered non-member of society. You really wanna have your identity affirmed by who you're seeing. Some people prefer not to have an app on their phone. They prefer to just use Alexa. So here's a way to link up with a coach or a therapist, just telling Alexa, hey, Alexa, I want a therapist. And you can connect with The Difference, which really, again, tries to be very available for frontline workers and first responders, particularly. So action items for all of us leaders. I think it's important that we keep in mind our workplace has to be as trauma-free as possible, not only for our patients and our clients, but also for our staff. We've got to hire a diverse workforce, making sure your on-site addiction and prevention staff reflects the population, and connecting staff to apps and programs that are structurally competent. We want qualified people out there, but we have to know where to look for them. And we need to partner with community organizations for pipeline programs. And again, make sure our EAP is staffed with people, again, who have done the work. And so here are directories. I saw somebody in the comments was like, you didn't mention therapy for Black girls. Well, there it is, okay? And there's therapy for Latinx, there's queer and trans therapists of color. We really tried to put together lots of resources. So I'll stop there and just say thank you to all that you are doing. Thank you for inviting me to talk with you.
Wonderful, Dr. Glover, thank you. So the next slide is really about everything that we've been discussing here and what we started when we started the discussion actually last session. We're talking about reframing with a racial equity lens. So just like the schemas that we spoke about last week, where we started to understand how they form frames and how we perceive and interpret our world, and how those heuristics or kind of like rule of thumbs or quick ways of making judgments and decisions. We can also reframe our opportunities to convey social justice. So these are, opportunities where we can, where evidence of implicit bias can have more overt forms of racism, and we can start to document disparate outcomes to identify where the issues are, emphasize the need for institutional policy change, and also to point to equitable and fair solutions. So in the meanwhile, I just want to thank you everyone for your time. Please come next week. We will be presenting on cultural humility and culturally and linguistically appropriate services. And standards. And so this will be another interesting presentation, all building on each other. So thank you, Dr. Glover. I wanted to thank Clyde and Tree. Thank you, guys.